Okay, so welcome everyone. My name is Selena Robinson, and I run Net Cancer Foundation, which my husband Simon set up, along with my lovely ambassadors, of which there are 1, 2, 3, 4 here today, which is amazing. I'm really looking forward to this talk, and so I will first of all actually just one quick next month's September Netchatter on the 29th of September will actually be an hour later, which is our 7 p.m. So I don't know what that is in your time, but just an hour later from where you are now. And I will just say that again at the end for anyone else that joins. Okay, so I'll just pass you over to Rachel to introduce this month's speaker. Thank you very much, Rachel.
Thank you, Selena. So I'm excited to introduce today's speaker, which is Brendon Herring. He actually works in the lab with me. And Brendon is an MD PhD candidate in the medical science training program here at the University of Alabama at Birmingham. And he's training under Dr. Herbert Chen and Dr. Bart Rose. His work focuses on the influence of genomic alterations and the tumor microenvironment on racial disparities in pancreatic neuroendocrine tumor outcomes. His work also aims to improve biomarkers for pancreatic neuroendocrine tumors in the clinical setting. As a Native American, he hopes to leverage his research to advocate for more equitable representation of racial minority groups in clinical trials and genomic studies. So with that, I'm excited to hear Brendon's talk today, and I'll pass it over to him.
Thank you, Rachel, and thank you everybody for inviting me to speak today. I'll go ahead and share my presentation. Okay, can everyone see that?
Mm-hmm.
All right, everyone, feel free to stop me along the way. Like I said, the presentation is about 30 minutes long, so we'll have some time for questions if you guys want to inquire further about anything. So my talk today is, as Rachel said, on the molecular influences of racial disparities in pancreatic neuroendocrine tumors. I don't have any financial disclosures. However, there's my Venmo if any of you are interested in changing that. That is a joke. So to begin with, you guys are well aware that pancreatic neuroendocrine tumors are these highly heterogeneous cancers arising from the cells of the endocrine pancreas. And these are divided into 2 broad categories. The first is the functional or hormonally active group, which occurs in around 30% of cases. And this obviously causes the severe symptoms such as diarrhea, glucose imbalance, intestinal ulcers, and heart failure. And then the non-functional group, which occurs in about 70% of cases. 58% of pNETs, or around 58%, it varies based on who you're reading, are metastatic on diagnosis. And there are a few non-surgical treatments available, and the ones that are available have varying utility and effectiveness. However, they do have a 100% likelihood of coming up on medical board exams. And they're important for that reason, but they're also important because the incidence of NETs has been increasing steadily over the past 50 years. Now, there are a lot of things that influence your survival outcomes or your survival chances in pNETs. And of course, one of those is whether you get surgery or not. So this was a study from the National Cancer Database looking at around 2,000 patients with non-functional pNETs. And generally, this showed all of the different surgical procedures for pNETs are up here, and the patients that did not get surgery are down here. And this depicts that surgical treatment overall was associated with better outcomes. Now, as many of you also know, is that surgical treatment is obviously heavily biased towards patients that have less aggressive tumors that have not yet metastasized. So that was an issue with this study. That brings up this other study that looked at around 700 patients from the SEER database. 79% of these patients had distant or metastatic disease. What you can see here, what's interesting about this study is that there's a large proportion of the cohort that was recommended to have surgery, but for some personal reason, they decided not to. In blue is the patients that were not recommended for surgery, and in green is the pagey that were recommended and then actually followed through with surgery. And so what you can see here is that even compared to the group that was recommended for surgery, but did not end up proceeding with it, their outcomes were around the same as those that did not get recommended for surgery. And those that did get surgery had much better survival times. So what this really indicates is that there's a clear-cut resection benefit to getting surgery for pNETs. And so now, in order to proceed, I kind of have to talk about the other things that influence overall survival or survival in general for pNETs. And one of those things is patient race. So this is a 2017 study that looked at the SEER database and included just under 4,000 patients, 13% of which were Black. And what you see here is that the Black patients had much lower survival outcomes compared to the white patients. And to describe that, I guess, in depth, Black patients more often have distant disease. They're less likely to have surgery. They have worse overall survival, worse disease-free survival, worse disease-specific survival. However, in this study, they found that if Black patients had surgery, there was no difference in these different survival outcomes. And while this study was controlled, that's a difficult thing to do, but was controlled for income, education, and insurance status, there's still the question as to whether this could be an issue with access to care. And now maybe that is the case, but the data that I'm going to show you indicates that maybe that's not the case for the reasons that you initially think. So to continue on from here, we have to bring up the current pNET resection guidelines, right? And so these current recommendations dictate that all functional tumors are considered for resection because of the severe symptoms that they can cause. However, non-functional tumors are resected based on the tumor size, which ultimately serves as a proxy for the likelihood of metastatic disease. Whereby tumors that are under 1 centimeter are typically observed. Those between 1 and 2 centimeters are subject to the clinician's judgment, and tumors over 2 centimeters are generally recommended for resection. But it's very important to note that most of the studies that these guidelines were based off of were conducted in predominantly white patient populations. So that brings us to the last, big clinical study that I want to visit with you guys, and that is this 2019 study that looked at recurrence-free survival in pNETs, and specifically looked at racial disparities. So this is just around 1,100 patients, 14% of which were Black. And what we actually found is, contrary to what I showed you earlier, is that the Black patients actually had a better 5-year recurrence-free survival. And had a higher incidence of lymph node positivity, which means that the tumor has migrated into the lymph nodes. But what's very interesting is this chart that I'm showing you is for the lymph node negative pNETs. That's where we saw the difference. But in lymph node positive pNETs, there was no difference in recurrence-free survival. And what this really indicates is that possibly earlier resection in Black patients prior to them developing lymph node metastasis may improve their survival outcomes. Now, we wanted to explore the value of the current surgical criterion and expound on the previous study that I showed you. And so we published a recent analysis where we looked at the National Cancer Database and the U.S. Neuroendocrine Tumor Study Group to analyze the incidence of lymph node metastasis in these pNETs that are under 2 centimeters, where they would typically be observed. Right. And what we found in the smaller of the two data sets is that Black patients had just under twice the rate of lymph node metastases in these pNETs. But in the larger of the two data sets, looking at just over 6,000 patients, Black patients were almost 5 times as likely to have lymph node metastases compared to white patients. So this is obviously a massive disparity. And so ultimately, what we conclude from these data were that Black patients have much higher rates of lymph node metastases in these tumors that are normally observed, that the current guidelines for surgery don't predict the malignant character of these tumors for Black patients. And ultimately, this indicates to us that there must be or may be some difference in the tumor biology that is increasing the propensity of these tumors to migrate earlier on in the disease course. Now, that prompts this other question, right? Which is, what are the racial differences that could be present between, different racial groups with a specific type of cancer? What biology could be different? And ultimately, the data that we have gathered over the past 20 or 30 years when we've been studying this has found many differences in the epigenetics and in the tumor microenvironment. Now, we actually know that epigenetics or DNA methylation changes specifically differ in healthy tissues among different racial groups. And some of these differential epigenetic patterns in between different racial groups are actually even present at birth. Now, also with respect to the tumor microenvironment, these are the tumor stroma and the immune cells that are within the tumor. This has been explored as a cause or explored as being related to racial disparities in numerous other cancers to date. And indeed, there are numerous epigenetic events that are directly influencing racial disparities that are being characterized in multiple different types of cancer, including breast, prostate, colorectal, and endometrial cancer, just to name a few. So ultimately, to explore and study differential genetic or epigenetic things among different racial groups, there has to be representation of these different racial groups within the genomic studies that are being conducted. And this is an issue, particularly for Black patients, because despite making up 13% of the US population, they make up only 1.7% of subjects in genomic studies of cancer in aggregate. And ultimately, as I began trying to study differences in the genomics of these tumors between different racial groups, and particularly in Black patients, what I found was that there was very little data out there that could actually be used to ask these questions. And as I was looking for these previously published available genomics data sets, I wanted to get a better idea of what the actual representation was of these different racial groups in these genomic studies. And so I did a systematic review of the literature, reviewing over 3,000 manuscripts, and used the NIH race category terms and natural language processing to evaluate all of these different manuscripts for either conducting, or rather both conducting some sort of genomics analysis, looking at RNA or DNA methylation, as well as those that included data on the race of their subjects. So ultimately, in screening for those two things, I found 13 manuscripts that actually conducted some sort of sequencing or genomic analysis and included data on the race of their subjects. And now looking into those 13 studies, we found that 9 of them analyzed the DNA, 3 analyzed the RNA, and 1 analyzed DNA methylation. These are just the actual assays that were used in these various studies, which are of various utility for extrapolating to other populations or making conclusions off of. And to get actually down to the patient level, as far as how many of each race group was represented in these genomic studies, we found that overwhelmingly white Asian patients made up the predominance of these patients. That was followed by Asian patients at 6.8%, patients that were described as other by the manuscripts at 4.6%, and only 1.3% of patients in these genomic studies were Black. That's the absolute number is 26, only 26 patients. And again, as I mentioned before, the representation of Black patients in the US population, at least, is actually a little over 13%. And so 1.3% puts them at around 1/10 of the representation that they should be to be on parity with that. So what I also should mention is that no patient race data was actually directly associated with the genomics data. So I wasn't able to do any sort of differential analysis to see what the differences could be using any of the currently published data sets out there. Now, that is, at least until I stumbled upon the AACR's Project Genie data set. And if you're not familiar with Project Genie, this is an aggregate of mutational panels. So these are, many of you might be familiar with MSK Impact or the DSCI OncoPanel, but these are usually panels of around 600 cancer-related genes where you're looking specifically at those genes for mutations. And what I'm showing you right here is just the different panels that were that had data available within the AACR Genie database, and showing you that in general, the distribution of those different panels for the Black and the white patients were similar. So in analyzing that data, I found 10 genes that were different, or that were significantly differentially mutated between these groups. And these genes ranged from what you might characterize as a more canonical tumor suppressor or oncogenes, p53 binding protein 1, CRKL, MAP kinase 1, CHEK2, NF2, and MUTH. But also, we found 4 genes that were differentially mutated that have direct roles in epigenetic regulation throughout the cell, namely SMARCB1, which is part of the SWI/SNF chromatin remodeling complex, KMT2D, which is a histone methyltransferase, MEN1, I usually skip MEN1 and say it last, EP300, which is a histone acetyltransferase, and then many of you will be familiar actually with MEN1, which is a tumor suppressor gene as well as a histone methyltransferase. And many of you are familiar with this gene because it's the most frequently mutated gene in pNETs according to our current genetic epidemiology of these tumors. And so again, our current epigenetic epidemiology says that these things are mutated in about 40% of pNETs. But we found that that rate was much lower in our Black patient population, around 17%. And so obviously this was very interesting in that, first off, this differential racial analysis had never been done before. And as I've already shown you, most of the mutational data and genomic data that we have out there is based off of white patients. So we wanted to really confirm this, as well as look at some other genes that may be of interest. And so we used our pancreatic or our pNET tissue microarrays. These are slides that have many patient tumor pieces on them so that we can look at all of them at once. And we assess these for DAX, ATRAX, and menin. Ultimately, these TMAs or tissue microarrays had 13 Black patients and 40 white patients. And essentially, by this method, if you see loss of staining, that indicates that there is a protein altering mutation in the gene, right? And so what we saw is that there was no really significant difference in the loss of staining in DAX and ATRAX, which are the other most frequently mutated genes in pNETs. However, while we saw that 11 patients in our white patient cohort lost staining for MEN1, none of our Black patients did, indicating that none of our Black patients had a protein altering mutation in the MEN1 gene, while our white patients did. So this was largely confirmatory of what we found in the AACR Genie data. And that prompted some interest in looking into some of the genes that came up as being differentially mutated in that analysis. Now, specifically, we were interested in the epigenetic regulatory genes because, as I showed you guys earlier, a lot of the differences that have been characterized in racial groups in cancer are at the epigenetic level. And so we took those 4 genes, KMT2D, MEN1, EP300, and SMARCB1, and we conducted a network analysis and literature review to see how these things could be interacting with one another and are they related. And ultimately what we found is, well, first off, yes, they are related to one another. And in fact, there are some functional convergences between them. So KMT2D works together with menin, or the MEN1 protein, to regulate histone methylation at lysine 4, histone 3 lysine 4. EP300, KMT2D, and SMARCB1 all act in concert to regulate histone 3 lysine 27 acetylation throughout the genome. And then menin, KMT2D, as well as SMARCB1 act at different points along the Wnt beta-catenin signaling pathway to inhibit the proliferation signal conferred by that pathway. And so ultimately, what we concluded from this is that there are these genes that are significantly differentially mutated between these groups, or that are enriched in Black patients, actually seem to have functional convergences with MEN1. So while there might not be as many MEN1 mutations in Black patients, these might be what you might call non-canonical nodes of mutation within that same pathway that is resulting in progression or even oncogenesis in pNETs. And this data has actually recently been accepted by Cancer Research Communications. You should be able to find the paper next week. So to summarize, yeah.
Before you move on that slide, John had a question about what the dashed lines mean.
So let's see. Gosh, John, I'm so sorry. I cannot remember off the top of my head what the dashed lines with respect to the solid lines mean. I will get back to you on that as soon as I'm done with the talk.
Well, as long as you tweet about this paper when it pops up with a DOI, then, you know, I'll check it out.
I'll make good on that promise. I promise, John. I appreciate it.
Thanks.
Okay, so to summarize the preliminary data thus far, we found that Black patients have much higher rates of lymph node metastasis at small tumor sizes that are normally observed, possibly influencing survival. Black patients and other ethno-racial minorities are highly underrepresented in pNET genomics compared to their representation in the general population. And then finally, there are differences in the mutation of key tumor suppressors, oncogenes, and epigenetic regulators between Black and white patients with pNETs. So that prompted my hypothesis that key elements of the epigenomic and transcriptomic landscape, tumor microenvironment, and intrinsic tumor properties differ significantly between Black and white patients with pNETs, influencing disparities in their clinical outcomes. And so this brings us to my first aim of this project, which was to determine racially distinct prognostic epigenetic and transcriptomic elements in pNETs, as well as assessing the association of those differences with patients' clinical outcomes. And then finally, to evaluate them as prognostic biomarkers. Now, I'm not going to spend too much time on this because I want to get to the results with you guys, but ultimately, we're satisfying this aim in a collaboration with Wayne State University, whereby here at UAB, this is our discovery data set. We have 23 Black and 25 white patients that we're currently sequencing. We're planning to do bisulfite sequencing to look at DNA methylation and RNA sequencing to look at the transcriptome. And then at Wayne State, we're going to use that as our validation cohort that has 36 Black patients and 96 white patients that have been sequenced thus far. They have done RNA sequencing as well as whole exome sequencing to actually look at the different mutations. And we'll be using these different data sets for various things. Mostly, actually, what I'll show you guys today is the RNA sequencing results that I have thus far. And ultimately, the plan is to integrate the data from UAB and Wayne State to do pathway analysis, transcriptomic subtyping, and then to associate those differences we find with patient clinical outcomes. We'll also be able to look at the differentially methylated regions between Black and white patients in these tumors to evaluate the regulatory landscape. And then finally, the whole exome sequencing we'll be able to use for rare variant discovery, analyzing mutational signatures, and then actually confirming some of the findings from the AACR Genie data set. So what I'm actually going to show you guys today is data from 14 of our Black patients and 16 of our white patients, and specifically the transcriptomic or the RNA sequencing data that I have thus far. And this is just showing you that these are age, grade, and sex matched as closely as we were able to. And they were also metastases matched too. So that being said, all of the tumors represented here are primary tumors. These are just we had 4 patients in the Black patient cohort that had metastases present at the time of resection, and 5 for the white cohort, respectively. So in doing this, to isolate the tumors from the stroma for sequencing purposes, I did laser microdissection, whereby we worked very closely with pathologists to delineate regions where there are concentrated tumor beds, and then we blast that region with a laser to cut that out, and then we isolate DNA and RNA for the sequencing from that. So ultimately, within this transcriptomic analysis, I found just under 400 genes that were differentially expressed that met our p-value and log fold change cutoffs. And what's very important to note is that the data I'm going to show you today is based off of self-reported race, not genetic ancestry. However, the ultimate analysis of this data will be using genetic ancestry with inferred SNPs from the RNA sequencing data. So I'd be happy to talk about that a little later on if you guys have more questions about it. Now, that said, I conducted gene set enrichment analysis with these differentially expressed genes and had some very interesting findings, namely, namely, what we found is that here on the left are the pathways that were activated, increased in our Black patient population, and on the right are those that were decreased in our Black patient population. And what we found was that a lot of the pathways that were upregulated in Black patients were things such as angiogenesis and blood vessel development. Vasculature development, indicating that these things increase the access of the tumor cells to the vasculature, as well as pathways that are that are involved in cell motility, cell migration, and cell locomotion, right? And if we think about the things that are required for developing metastatic disease, access to the vasculature and cell migration are two of the seminal things that are necessary for developing metastases. So this was obviously very interesting and maybe very impactful for explaining some of the clinical findings that we've seen so far. This is really just, oh, I'm sorry. The other thing I wanted to show you from this is that we saw downregulation of some humoral immunity related pathways in the Black patient tumors as well. So that's an important thing that I wanted to note to you also. And this is really very similar to what I was just showing you. Except that this is a network showing the overlap of these different gene sets. So these are, you might think of these as like functional modules that are differentially expressed between these two groups. What the module down here is that angiogenesis and cell migration module. And what you're seeing right here is that downregulated humoral and antibody-mediated immune pathway module. So, we did Ingenuity pathway analysis just to look at this data another way. And I don't want to belabor this too much, but what I do want to show you is that generally the Ingenuity pathway analysis agreed with the gene set enrichment analysis in that we saw cell locomotion and angiogenesis pathways that were upregulated via this algorithm as well. So that brings me to my second aim, which was to evaluate known prognostic biomarkers to evaluate their utility among different racial groups, as well as determining the influence of racially distinct component of the tumor microenvironment on disparities in patients' clinical outcomes. And we wanted to do this using something called the Akoya Codex, which is similar to geomics, if you're aware, with different spatial transcriptomic analysis platforms. And we were doing this in collaboration with Clayton Yates at Tuskegee University, who is a world-renowned researcher doing very similar work to us in prostate and breast cancer. And so this is an example of some of the analysis that his group has published on the Akoya Codex. And really what this is multiplex immunofluorescence, if that means anything to you, whereby you can test, well, the company says up to 104 different antibodies on the same tissue slide. In reality, 104 is probably pushing it, but you can still look at a lot of different antibodies on the same tissue. So what you see here is CD8, CD68, and PD-L1 all stained on the exact same tissue slide. And you can see that depicted here as well. What this really allows you to do is to use or to conduct cell type subpopulation analyses to look at gene expression in your cell population of interest. And so what he's depicting here is this transcription factor Kaizo that he's found to be important for influencing racial disparities in both breast and prostate cancer. And he's showing the different spatial analysis of the different spatial expression of Kaizo in the tumor cells in Black and white patients and how that relates to differences in their overall survival. And as I said, this is the publication that this data draws from. So with that all being said, this is one of the preliminary images that we generated. As of right now, we're evaluating 22 different proteins using the Codex platform. And ultimately, the markers that we're evaluating right now are all ones that have been shown in various studies to be prognostic for outcomes in pNETs. But as I showed you before, many of the studies that actually look at pNETs are predominantly of white patients. And so inferring that these prognostic markers were established using white patient cohorts, we thought that was an important thing to evaluate. And so what you're seeing here is again, the markers that we're evaluating are DAX, ATRAX, and MEM1, which are those commonly mutated pNET genes. Also our neuroendocrine identifying markers for cell type population analysis. We're using chromogranin A and synaptophysin for that. And then various prognostic markers, including the somatostatin receptors 2 and 5, progesterone receptor, alpha internexin, a molecule called PAM that's involved in hormone metabolism, indolamine 2,3-dihydrogenase, which is also involved in hormone metabolism and immune system regulation, CD36, which is a free fatty acid receptor, and then podoplanin, which is a lymphatics marker. We're also looking at various immune markers, namely CD3, CD4, CD8, PD1 and PDL1, CD163, which is our macrophage marker, and then calreticulin. Now, unfortunately, I can't show you guys all the, the fancy analysis today because I'm still doing it. But what I do have to show you is the actual images that I'm working on processing right now. We have various tissue microarrays that we're using this on. This is one that we've generated from exclusively metastatic neuroendocrine tumor samples. This is another TMA from a previous project of ours that we're using with this. And then finally, this is actually my favorite right now. This is of our normal pancreatic tissue that we're using as somewhat of a control. And what might be really interesting to you guys is synaptophysin is in pink here. And if you know, synaptophysin is a cell type specific marker for not only neuroendocrine tumors, but for pancreatic islet cells, which are the cells that these tumors originate from. And you can see this kind of starry sky appearance of the pancreatic islets throughout all these tissue cores that I just think is really pretty. And so we are expanding this analysis right now with tissue microarrays from our collaborators at Emory University, WashU in St. Louis, UT Southwestern. And then this spot right here is for Yale, once we confirm our getting some tissue from Pam Kunz at Yale University as well. And so in conclusion, patients from minority racial groups are heavily underrepresented in PNET genomic studies. We also found that MEM1 is much less frequently mutated in Black patients compared to white patients with PNETs, but the mutations in epigenetic regulatory genes that are enriched in Black patients appear to converge on functional pathways with MEM1. We also find that pathways related to blood vessel development and cell migration, representing key elements in development of metastatic disease, are significantly enriched in PNETs from Black patients. And then finally, we conclude that current size-based resection guidelines are inadequate, and that novel biomarkers may be beneficial in guiding decision-making for PNETs. And with that, I'd like to thank my mentors, thank Rachel, my collaborator in the lab, and all of my lab mates, our collaborators at UAB Pathology, Tuskegee, and Wayne State University, as well as our funders, number one being NANETs, without whom none of this would be possible, as well as our other funders. So with that, I'll take any questions you guys have.
Thank you, Brendon. That was an excellent talk. We do have one question in the chat. Angaraj has a question. He says, very interesting. Is the reduction in immune-related genes related to the lifestyle of the patients? Also, I'm still trying to understand what could lead to such a striking difference in gene expression between white and Black populations?
Yes, thank you for that question, Dr. Sananam. I think as far as the immune-related genes, I actually read your paper that that analyzed this recently in pNETs, and so I think it's an interesting question as to what the impact on the environment is on that. I think it's possible that that could be a factor. Ultimately, and really this is anecdotal based off of what our collaborator Clayton Yates has talked to us about, is that what he is seeing in breast and prostate cancer seems to overlap a lot with our findings, in that there seems to be downregulation of APCs, as well as penetrating T cells into tumors in Black patients, as well as the immunosuppressive, enrichment for M2 macrophages and decreased efficacy of the T cells, or sorry, I should say increased exhaustion of T cells within the tumor in Black patients compared to white patients. And so certainly it might be a product of differences in the environment, but I think also it might be just polymorphisms in the immune cells themselves, possibly differences in the antigenicity of these tumors. I think they're difficult but good questions. and then I guess the other, to get at your other question as to what could lead to this striking difference, I think one of the things is that there are big differences in minor allele frequencies and really mutations in many genes in Black and white patients with various other tumors. And so because so much of our data, because Black patients are excluded from so much of the genomics data that's out there, we don't know if there is large-scale enrichment for mutation in other genes that could be influencing perhaps the molecular subtypes that these tumors from Black patients tend to sort into. And so maybe that's what's influencing that, is actually the genes that are mutant in these patients. But then finally, I think that there are baseline differences in the epigenetics. Given that these tumors are highly epigenetically dysregulated, I think that that could be influencing the gene expression heavily as well.
Brendon, this is a great talk. This is also, your answer to my question is, sure, it makes sense. However, I wanted to kind of take this opportunity to also clarify, because this is quite interesting. And as you mentioned, in gastric cancer between Asian versus Caucasian population, obviously there are differences in the immune genes. But my understanding here is that you showed there are downregulated immune genes in the Black population compared to the white. Am I correct? So that's where I'm just kind of, it's interesting, and I'm kind of puzzled by what makes the genes go down. I know there's going to be multiple factors. We cannot just allude to one, but I'm just kind of wondering, because this is a striking difference. So in breast cancer, we did some, recently we published in Translation Oncology, where we compared triple negative breast cancer between Indian population and the Caucasian. Unfortunately, we couldn't do a head-to-head analysis of gene expression differences because we didn't have one cohort of both the Indian and Caucasian population. However, we analyzed by the subtypes, as you mentioned at the end as well. We developed subtypes from Indian population and similarly derived the similar subtypes from the Caucasian and compared them. But unfortunately, we couldn't find any difference in the distribution of the subtypes, for whatever reason. And it looked like majority of the cases in triple negative breast cancer, the gene expression levels are very similar. So we are currently mining to see if there are copy number, if not epigenetics, but copy number or any mutational differences that exist in them. However, in your case, that the striking difference of the gene expression of several genes definitely is very interesting. It also goes back to the gastric cancer as well. So I just was thinking out loud that, further looking into this lifestyle, because that seems to be one of the key events for many cases, or even epigenetics for that sake. So that's why I asked this question.
Yeah, of course. And it's really interesting that you bring that up, because one of the things I didn't really have much time to talk about today is this SPINK1 pancreatic cancer pathway. And typically when we think about SPINK1 and really, this pathway in general, it's really more closely related to the development of PDAC as a result of chronic pancreatic inflammation. And so I think that, obviously that there are going to be differences in exposure or environmental exposures and lifestyle habits between different racial populations as a result of differences in culture. But I think that this may be influencing that in some way, in that we do see higher rates of chronic pancreatitis in the Black patient population, particularly in the south of the United States. We see higher rates of type 2 diabetes. And so I think that this does prompt that as an interesting hypothesis, and possibly a mechanism by which we're seeing, just differences in the development of this disease. And so, I think at this point, we definitely can't discount lifestyle factors, and ultimately, it's going to take increased dimensionality of the data, and of course, a larger sample size for us to really be able to resolve that.
I mean, this is interesting again. The SPINK one, it's true. We noticed that as a part of one of the pancreatic adenocarcinoma subtypes we published earlier back, which we call exocrine-like. Unfortunately, in the US, people don't believe in the exocrine or ADEX subtypes. But that brings to the point that the SPINK one, I haven't noticed that in neuroendocrine, so this is interesting that you've noticed, especially in the if it's in the Black population. Then it also goes back to the question whether it's a combination of adenocarcinoma plus neuroendocrine. I'm blanking on the jargon of that. So is there a possibility that a combined adenocarcinoma plus neuroendocrine could be part of that, any patient that's kind of showing up here?
We did really heavily screen. That's one of the obviously this is a rare cancer, but we did very heavily screen the patients that we chose for this. Very close collaborations with pathology to ensure that these were neuroendocrine and that there weren't mixed endocrine exocrine neoplastic populations. Things can fall through the cracks, but I guess that ultimately, while I can say I'm pretty certain that that is the case, I think that increasing our sample size will help to resolve any inaccuracies that might have been insurmountable, even by the pathologist going through and being very meticulous and confirming that these samples were going to be valid for the study.
No, I appreciate that. It's very difficult, but it's a great talk. Thank you.
Thank you so much.
Okay, we've got about 4 more minutes. Does anyone else have any questions? Okay, well, if there are no more questions, we can go ahead and wrap up. Thank you, Brendon, for talking today. It was an excellent talk. Selena, did you want to say a couple things before we close the meeting? Oh, you're on mute.
Sorry. Thank you very much, Brendon. That was amazing. And thank you for giving up your time today. And just to let everyone know that the next Netchatter is Thursday, the 29th of September at a slightly later time of 7 p.m, where we have Dr. Pamela Coons speaking, yet to give me her topic. But that will, as soon as I get that will be advertised. So just thank you all very much for attending. And that was really interesting. And I'd like to do that kind of thing again, I think. I think that was good. Yeah, really good, really interesting.
Thank you. And thank you so much for having me. Obviously, if you guys have any question about the work, please, you can reach out to me on Twitter or at my email. Yeah, thank you again for letting me use your today. Yeah, no, absolutely. We encourage all of you just to get in contact with each other. That is the whole point of these meetings, for you all to be able to collaborate with each other. So thank you very much. All right, thanks everyone. Thank you. Bye-bye.
Thank you.
Bye.
Bye. Bye.